And there have been many changes in terms of the surgical pathology. And for the old days, we are concentrating on the distal margins and then circumferential margins and then grade of the planes. Could you, comment on that? So, how important is the surgical pathology in terms of treating rectal cancer? And there have been so many changes. So,
well, I personally, of course, as a pathologist, think it's very important. I think the whole focus in the 80s was on the distal margin and how long your margin had to be. But we only find that 1 or 2% of patients will actually have an involved distal margin. So surgeons are pretty good at estimating the distal margin. But we find a big variation involvement in the circumferential margin, so the margin actually around the tumour. And that can be involved in poor surgery in a third of cases, but in good surgery in under 10% of cases. And that's where we'd like to see you heading towards. So the margins are really important. I think our assessment of the response to therapy is quite important, and using a standardized method of assessing complete response. The newer molecular markers don't have a lot to offer in rectal cancer at the moment, and really what you need to do is to concentrate on doing high quality standardized pathology, which the surgeons get to see, and you get to discuss the planes they followed, which we've been able to demonstrate in multiple studies now are actually really, really important.